I am a primary care sports medicine physician based out of Fairfax, Virginia. I help run a sports medicine fellowship out of Fairfax Family Practice, and I inherited that program from Dr. Tom Howard, which I feel fortunate that we'll hear from him during this symposium later today as well. I want to thank Chad Holsapple and Matt Miller and everybody else, both at the USIS for Belvoir Sports Fellowship, as well as the physiatry residency at Walter Reed for helping to put this together. I think it's a great collaboration, and I feel like it just gets better and better every year. I'll apologize ahead of time, as we've had to adjust how we do a lot of things with virtual meetings at home. As you can see, I'm at home as well, and I may pull the shutter over my camera every so often so that my kids are walking in the background won't get too distracting. So I'll apologize for that ahead of time. But it's really the onus for my talk today is really to provide an overview of regenerative medicine and orthobiologics as they apply to the treatment of musculoskeletal and also to not too much of a lesser extent neuromuscular medicine in sports medicine. This talk kind of originally took shape when a few years ago when I had fellows who would ask me, hey, what's with all this regenerative medicine stuff? And they sat down and said, can you just do like a big unload or a dump of what's out there for us just so we've heard it all? And that's really kind of the rationale behind this talk, is to provide a kind of overview, to kind of throw a bunch of different terms at you guys, and to lay out different modalities of orthobiologics and regenerative medicine and define them so you have a working knowledge of them. All right. And we're not going to get too much in depth into any one of them. We'll probably pause for a little bit and emphasize a few of the more commonly used modalities that we use. But I've also included some things that you may hear about that you may not encounter too often, but just so that when you do hear about it, it's not too foreign for you. Okay. I do not have any relevant financial disclosures. Okay. But by its very nature, I would say that much of what we do in regenerative medicine is much further ahead of any kind of FDA indications. And so by its very nature, much of what we do can be considered off-label or no label, really. So again, my objective today is to provide this kind of broad overview of these regenerative therapies and kind of what I'd like to call a lay of the land approach, kind of a broad view of regenerative medicine. I will dip into the literature and some evidence when it comes to some of these modalities, but really just I'm really kind of not using that as a detailed, comprehensive point counterpoint appraisal of the evidence for and against regenerative medicine, but rather I will make mention of the literature here and there merely to illustrate the rationale behind the use of these. Okay, hopefully we'll be able to generate some neat discussions later. I know that for the remainder of today, we have several other talks that go into a little bit more detail into some of the things we talk about, but hopefully this will provide a good basis for you guys to start with. I will warn you that some of the stuff that I'm presenting is going to be a little on the dry side, but I promise you that some of this information, no matter how dry it is, will serve you well if you just tuck it into the corners somewhere in your brain. So just taking a brief look of the lay of the land of regenerative medicine, as you can see, there's a lot out there, and it ends up being in this kind of alphabet soup sort of a situation. People start throwing out acronyms: PRP, PNT, BMAC, MFAT, etc. And so we're going to try to kind of decipher some of this alphabet soup. And I would probably preface this by saying that about 2/3 of what I'm presenting is something that's available to us in the US. I'm a civilian, so it's a lot of what I do is colored by very much so about how much things cost in the face of how much I can get reimbursed. But I think those are important considerations even in the military when you think about resource allocation. So about 2/3 of what I present is going to be what is available to American physicians. And about 1/3 is going to be things that are either not currently available in the US, perhaps investigational, But patients have actually come and asked me to discuss this with them and counsel them because it is available abroad, and many patients are willing to travel to get some of these treatments. So I think it behooves us to at least have a working knowledge for some of these modalities if we're going to really be able to serve our patients well. So about 1/3 of that, we'll talk about that as well. So, how big is this, how significant is regenerative medicine? And, like Chad had mentioned, this is a very rapidly growing and evolving field. And it's been doing that for, at this point, decades, really. But, just to take a look at the current state of the business side and the significance of regenerative medicine, orthobiologics. And I won't get too much into the details, but you can see here, as recent as last year, you have reports, cataloging over 917 companies generating, designing, and pushing to market different regenerative medicine products, whether that is an actual biologic that you can inject, or whether that's a kit or a system in order to process such a biologic at the point of care through autologous specimens from the patient. And I mean, looking at even 5 years ago, this is actually a little while ago now, in 2015, in the US alone, $93 million in revenue were dedicated to the use of regenerative medicine in osteoarthritis. Now, that's a lot when you kind of think about it. And as time goes on, more and more clinics are starting to market themselves as regenerative medicine clinics, offering quote unquote stem cell treatments. And of course, you can see here in 2018, 716 US clinics were advertising themselves as being able to provide stem cell treatments. And of course, with this rapid growth, we have a huge variety, to put it lightly, a huge variety of different practice patterns, different levels of vetting, and I guess, I would probably say different levels of transparency in the way they practice. And so it behooves us to, I think, be able to kind of understand what we're talking about, so we can actually consult our patients and help guide them in making good, mindful decisions. Here's another blurb I think is useful for us, especially private physicians, when we think about costs. This is 2018 through surveys trying to find average patient out-of-pocket costs for some of these treatments. And it averaged between $700 and $900 per treatment for PRP across the country. Stem cell treatments, which were mostly adipose and bone marrow aspirate concentrate, ranged between $7,500 to $10,000 when it comes to that middle of that peak. And you'll find, of course, prices on either side of that as well. But I think it's kind of an interesting way to kind of frame what we're doing. If anybody here doesn't recognize the storefront behind us, this is Stemgenics, which was actually, drew a lot of attention a few years back. A company in California that was actually shut down by the Federal Trade Commission and the FDA for bankrupting a number of patients, providing misinformation and false promises, and they were shut down for this. And so I think that, we kind of owe it to ourselves and our patients to be able to protect them from clinics that have should I say, different business practices when it comes to medicine. And so just illustrates that cautionary tale. Now, I don't think any regenerative medicine conference is complete without at least a mention of the legal and regulatory environment in which we practice today, because I think that, more so than perhaps in many other areas in medicine, regenerative medicine, orthobiologics, and the nuances of the regulatory environment really go hand in hand currently. And so just to kind of help, keep, the fellows and residents here on the conference out of trouble, okay, these are two terms I really want to highlight here, and that is homologous and minimally manipulated. And currently, what that means is that, you know, the Public Health Service Act, Section 361, and you'll hear that number thrown around all the time, basically states that for point-of-care autologous cell therapies, and that's what we're talking about, that they categorize certain treatments as being homologous and minimally manipulated. So what does that mean? So it basically means, in homologous, it means that the intended target tissue, target site of that tissue that you are transplanting, okay, and the tissue origin, where you're taking the tissue from, must have a similar basic biological function, okay? So an example might be platelet-rich plasma, which we'll get into. So if you're treating a tendon, you could argue that, well, bleeding happens in tendon and platelets have, you know, have activity in tendon in those circumstances, so therefore it is homologous. That's a very basic, crude interpretation of that. But I will say that the FDA does not provide any further details other than this definition for homologous. So it's important for us to keep that in mind. In addition, the FDA also defines appropriate point-of-care autologous cell therapy usage as requiring it to be no more than minimally manipulated. So what that means is that while processing can occur with whatever tissue or specimen that you get from the patient, is that you cannot process it such that you change the tissue or cell's biological characteristics. Okay, so for example, being able to spin down a specimen to concentrate it and isolate certain physical components of, say, whole blood in PRP as an example, would be considered minimally manipulated. However, enzymatic digestion, ADI lasers to change the biologic activity of adipocytes, genetic modification, these are all considered more than minimally manipulated. And so basically what the FDA says is that if you are using an autologous cell therapy that is not homologous and more than minimally manipulated, that you need to submit an application for an investigational new drug or a biological laboratory application, both of which is accompanied by hefty fees of millions of dollars, because these applications are aimed at, are really intended for pharmaceutical companies and other large companies. And so failure to do that results in hefty fines and or jail time, worse. And so I think those are two terms to remember. So I'm going to say that several times during today, is that if you encounter a new technology that is to be where you're processing tissue at the point of care, currently under the current rules is that you have to make sure that it's homologous and no more than minimally manipulated. So stay out of trouble. All right. So, all right, with that, we'll move on. So regenerative medicine has a lot of different components, and it can be broadly defined as treatment modalities aimed at trying to at least with the intention of eliciting some sort of healing or regenerative or adaptive response. And so we'll first start off with therapeutic microtrauma. Now, Dr. Hosupple mentioned this a bit, and I'll dive a little bit into it, but we've got a lot to cover, so I won't spend too much time on it. And essentially what this is the use of some sort of instrument, usually a needle or a scalpel, in order to produce small micro-traumatic wounds inside a tissue. So for example, taking a percutaneous needle, poking some holes into a tendon. So you are going through the skin using a needle, poking holes, or otomy, right, of a tendon. So tendinotomy, and that's where that that's where that term comes from. Or perhaps using a scalpel or a cutting needle tip in order to produce small slices in a tendon, so-called fenestrations, for the purpose of softening scar, perhaps lengthening a fibrosed and contracted tissue, but also to cause a local inflammatory and healing response. And that's really the goal here. So in the upper right-hand corner, you can see this ultrasound picture of a needle being guided into the lateral epicondyle and the common extensor tendon here, so-called tennis elbow, in an attempt to perform a percutaneous needle tenotomy of that tissue. You can do this with the scalpel as well. And then, of course, there, just like as Dr. Holsupple mentioned, there have been technology that's aimed at trying to augment this type of rationale, where they basically add, not just for therapeutic microtrauma, but perhaps add a mechanism by which to remove and debride devitalized tissue that may be hampering the healing and remodeling process. So one that he mentioned was this ultrasonic Tenix type of procedure, and that's a brand name. But what this is basically using phaco emulsification, which is a technique that's used for debriding cataracts, where they use a needle that is moving back and forth at a fairly high rate, and using suction at the same time to essentially debride a degenerative or devitalized area of a tendon in this case. A newer kid on the block is TenJet, and what TenJet does is, rather than using phacoemulsification, they use a different mechanism by which to debride the tendon, and that would be kind of a hydraulic rheolytic debridement, where they have a high jet of fluid that almost kind of power washes the inside of the tendon to debride that devitalized tendon. And so for those of us who are familiar with angiojets, where people try to basically kind of remove, thrombus from within an artery or a vein, that's essentially the same idea. Okay. So looking at, therapeutic microtrauma, just some studies to illustrate the rationale, all right? Here's a study by Hausner et al. In 2009 looking at needle tenotomy for chronic tendinopathy. And this was just, several different tendons here, some commonly tendons that we treat, patellar, Achilles, etc., hamstring. And they used the 27 and 22 gauge needles. And the studies here, they use 30 needle passes. And so a lot of times when I need to document how many needle passes, some insurance companies will say that that you have to do 50. That's their categorization for being able to use that code. So you got to be familiar with what your payers and or what your protocols stipulate as the number of required needle passes. Okay, but in this case, you can see that, looking at visual analog scale, follow-up at 4 and 12 weeks, they found statistically significant improvement in pain. And so there is a rationale for this, to use this to treat. And I remember even before we really start to dive into using Prolo and PRP in our clinic, I remember utilizing this type of technique, just using landmark base without ultrasound guidance. So next we'll shift to traditional prolotherapy or proliferative therapy. And like Dr. Holsupple mentioned, this has been around for a long time. And only in the last couple of decades have we started to look at this more scientifically in more recent years with some good literature. And essentially what this is to the use of some of a medication or a chemical to cause, with the intention of causing inflammation and sort of a regenerative response. But by definition, these are usually non-biologic. They're organic, but they're not non-biologic substances in order to elicit this sort of response. There are 5 categories as to the type of proliferants or chemicals that can be used as prolotherapy agents. And so we'll kind of go over them, and they have different rationales as to how they accomplish this, causing this inflammatory response in order to elicit a healing response. So osmotics is probably by and large the most common mechanism that people will gravitate to when they use prolotherapy. And basically these are substances such as hyperosmolar dextrose to dehydrate cells in order to cause kind of this dehydrating damage to cells in order to attract circulating and local leukocytes to the area and to respond to those abnormal cells, then produce a kind of wound healing response. And I would say of all the different proliferants, hyperosmolar dextrose is by far the most commonly used proliferant, not just in the US, but worldwide. The next category we'll talk about is irritants. And what they're doing here is these are irritants that cause damage to the cell membranes directly, which then makes them antigenic, which also attract white blood cells and produce a kind of a wound healing response. And I would say these have kind of fallen out of favor just because it's a little hard to contain the degree of cellular damage from this, but it's still being used relatively widely. Another category might be chemotactic agents, which triggered an enzymatic response. These include sodium moreuate, and we used to use this a lot more than we do now. But during the earlier days, I would say this was maybe a little less frequent than dextrose, but I would say it's been a long time since I've used sodium moreuate. It does seem to produce a much more robust inflammatory reaction than dextrose, and perhaps a little bit harder to contain. Particulates is another type of prolotherapy that's also not used very often. And what these are basically small particles that attract macrophages in order to phagocytose them, which then activates the macrophage. And we'll talk a little bit about macrophages later, which then elicits a healing response by the macrophage activity. And then finally, I'll make short mention of sclerosants. And this is something that we've seen increased use in recent years. But these include medications and chemicals that are meant to cause an inflammation response, actually to cause some fibrosis in order to obliterate pseudocapsules and vessel lumens. So, things like polydocanol, doxycycline. I don't know of any of my colleagues using talc powder anymore, but these should actually trigger a kind of a little flag that you go, wait a sec, I've seen these used in things like pneumothoraces and things like that. And yeah, that's exactly right. It's by the similar mechanism in order to obliterate those. And symptomatic knee osteoarthritis. Now, they used both an intra and extra-articular treatment using dextrose, and found that follow-up at 1 year statistically significant improvement over using saline. And this study has been, other groups have tried to repeat this and have found similar results, which I'll mention soon. Other studies have looked at using prolotherapy in other musculoskeletal conditions, and rather than go through all of them, I'll just cite this systematic review of dextrose prolotherapy for chronic musculoskeletal pain. But in that systematic review, they included not just articular disease such as osteoarthritis, but they also looked at tendinopathies and other musculoskeletal ailments. So this is a more recent study looking at Sert Sen et al. And this is another attempt, just the most recent attempt to try to replicate and reproduce some of those results from the Robago study looking at symptomatic knee osteoarthritis. And they found similar favorable results. So I'm going to shift gears a little bit and talk about ozone therapy. So what we're talking about here, it's not purely ozone. So, ozone is a triatomic, heteromer of oxygen, right? And so basically, instead of having 2 oxygen molecules, you have 3 atoms, okay? What most ozone therapy is using a mixture of O2 and O3. And what you do is you get this oximizer, this kind of machine here that produces ozone from a canister of O2. As far as the mechanism of action, there's a lot of theories, but it hasn't really been worked out, the precise mechanism of action. But in vitro, it's been shown that ozone can stimulate the production of scavengers of free radicals, and may perhaps indirectly stimulate the production of various cytokines as well. And they can stimulate oxygen metabolism in the area, whether that's at the level of the mitochondria or at a larger cellular level. It's to be debated. Some people will pair this with other treatment modalities, and you'll see this theme throughout regenerative medicine, where people will use combinations of different treatments with various protocols. But one idea is to kind of pair up ozone therapy with prolotherapy. And there's this catch-all term called Prolozone, which is actually a specific combination of prolotherapy, vitamins, and ozone. And that, of course, has actually been studied much less than the individual parts of that cocktail. But looking at some of the data surrounding ozone therapy, and there is actually some promising information, at least for short-term benefit. Here's a study from 2017 looking at a double-blind, placebo-controlled RCT of intra-articular ozone treatment, again a combination of O2 and O3, in the treatment of symptomatic knee osteoarthritis. 98 patients, and they looked at function scores as well as symptomatic scores with the visual analog score, WOMAC, etc. And they injected once a week over 8 weeks, and they followed them up at 16 weeks and found statistically significant improvement of all the scores, favoring ozone over the placebo of saline. There's another more recent study in 2019 looking, and I think this is interesting because up until more recently, I've always considered ozone to be more of an intra-articular type of treatment. And really, it's from what I've seen, it's mostly short-term benefit. And the way I kind of think of it is that if you consider its in vitro mechanism of action as being a scavenger of free radicals and being relatively anti-inflammatory, it's sort of like a non-catabolic anti-inflammatory, if that makes sense. And so in my mind, I always thought of it as relatively a shorter term solution when it comes to pain, but I always considered it to be more of an articular type of treatment. But here's an interesting study looking at the application of ozone therapy versus corticosteroid in the treatment of a soft tissue type of degenerative condition, such as plantar fasciopathy. Okay, looking at that, and basically in the short term, as they described at 2 weeks, that the symptom improvement for both corticosteroid injection under ultrasound guidance versus ozone was similar, but at 12 weeks that there was statistically significance favoring ozone injection over steroids. I'm going to shift gears to another modality that's been used that has really fallen out of favor, except in certain groups. Okay, and that is aqueous testosterone. So this is very different from the testosterone supplementation that people will get to treat systemic hypogonadism, which is usually more of an oil-based or hydrophobic sort of injection. This is an aqueous hydrophilic, non-esterfied testosterone injection. And what they're trying to go for here is essentially capitalizing on the non-genomic effects of testosterone. It's often used with a similar aqueous formulation of human growth hormone. And together what they're trying to do is, rather than increase the translation of DNA, transcription and translation of DNA into protein products, it's looking at more the peripheral adjunct cellular effects. Such as modulating intracellular calcium and changing the metabolism at the mitochondria level, for example. It's generally in the U.S. not available as a drug that you can just order. You usually have to use a compounding pharmacy in order to compound it, and it's very tightly controlled because of the nature of testosterone being a compound that has a high abuse potential. Tom Raven and his groups is probably his colleagues are among the group that has studied aqueous testosterone the most, and this is one of his larger studies looking at aqueous testosterone injections for non-radicular low back pain. They used it as almost kind of how you would use proliferative therapy, where under fluoral guidance they injected it to various soft tissues, ligaments, tendons, etc., where those are known to attach to the bone, and they found a significant decrease in pain and disability at 1 year. This was more of a case series and wasn't placebo-controlled, but it was just another one of his studies that illustrated the rationale behind it. Before I move on from this, I will tell you that we had at Fairfax Family Practice, we had used this for a little bit, and what I found was that, anecdotally, I'll tell you that people either really responded to it or they really didn't. And what I meant by that is that not only did they not respond, but it was fairly inflammatory. Which was, and that's true for a lot of what we're talking about today. But I would say patients didn't tolerate this as that well when they kind of had these more idiosyncratic reactions to this testosterone. Now, it might be that it was just from our compounding pharmacy and the way they made it. That's difficult to control, but it's just something to keep in mind for what it's worth. Autologous blood. So this is something that's been used for years, and what you're using here is you're basically just the way it sounds. You're getting some peripheral blood, perhaps using some anticoagulant, and I would recommend that if you do decide to use this, that you do mix it with some anticoagulant because it tends to clot pretty quickly. And the rationale is you're using blood to usually paired with tenotomy to treat soft tissue degenerative conditions such as tendinopathy in order to elicit that inflammatory healing response. Like proliferative therapy, like prolotherapy, it's relatively inexpensive, but it's also a little less predictable and a little bit less user friendly as far as manipulating it. But just as a word of caution, this is only for soft tissue pathology like tendinopathies and ligaments. And I think it goes without saying, but I'll say it anyways, that you do not use this for osteoarthritis. Okay, RBCs and neutrophils are bad inside the joint, so you don't want that. Okay, so just keep it to tendons and perhaps some ligaments if you choose to use this modality. And there is some rationale in the literature to illustrate, to support the use of autologous blood injection, or ABI for short. And here's a study in 2007 looking at ultrasound-guided needle tenotomy with autologous blood injection for recalcitrant patellar tendinopathy. Fairly good numbers, 47 knees with a reasonable follow-up at just shy of 15 months, and found an improvement in pain and function over baseline. And what was interesting, and I wish we would see more of this, just because, and I'm not sure about the implications, but they also described the ultrasound appearance of the tendon before and after treatment, and found it, at least through their interpretation, an improved in ultrasound appearance of the tendon. So we're going to slow down the rate of my talking for a little bit when we talk about platelet-rich plasma. I know we've got some really great talks coming up for the rest of today looking at some of the other regenerative modalities, but I'd like to just pause a little bit to talk about PRP. Most people here are going to be reasonably familiar with it, but I think I'm going to dive a little bit more into details so when you hear different terms surrounding PRP, like platelet lysate, platelet releaseate, that it'll kind of make a little bit more sense to you. So what is autologous PRP? So if you just kind of think back to medical school again and think about laboratory medicine, if you take a column of whole blood and you centrifuge it down, you spin it down, you've got these three layers, right? You've got your packed RBC layer right down here. Then you have your plasma layer on top. And then in between, you have this white kind of grayish zone that we call the buffy coat. Okay, and the buffy coat is where you have your leukocytes, your white blood cells, your platelets, some heavier proteins, for example. It's actually a fairly mixed, there's a lot of stuff in that buffy coat, and we're going to go over buffy coat analysis in a little bit. But this is also where the platelets lie. And the rationale is that the body is fairly elegant in that if something happens to the body's responses typically will not only serve a primary focus, but serve as a springboard for other processes that are important for resolving that insult to the body. So if you, for a moment, think about if you get a cut, right? If you get a small cut, laceration, what are the priorities? You're gonna need to stop bleeding. You're gonna need to protect yourself from infection and debride any devitalized tissue, and then you're going to have to heal. Well, it turns out that platelets play a role in all of those processes. And so it's actually pretty amazing to think the body can have things that serve a role in all these different processes. So platelets obviously play a role in hemostasis. We all are pretty familiar with that. But the platelets also carry a significant payload alpha granules and other kind of small vesicular bodies that actually contain several signaling proteins and chemotactic and growth factors that are important in the other functions of platelets beyond hemostasis. That includes calling in white blood cells, calling in and recruiting surrounding macrophages and other phagocytosing cell types in order to help debride and protect against infection, but also to call in several other leukocyte populations in order to start the regenerative and healing and reparative processes in order to heal that wound that we just sustained. And there are a lot of these chemotactic factors. And here's just a list of some of them. And we're not going to go over all of them, but some of them that I'll just make mention because you'll hear it in the literature over and over again is platelet-derived growth factor is a big one. VEGF is another one, vascular endothelial growth factor, and several different interleukins, okay? And then, of course, your TGFs, TGF alpha and beta. These are ones that you'll hear about, and actually there's been more interest paid attention to the actual growth factors. And as time has gone on, other products are coming out on market where they're actually looking at, well, what if we can isolate some of these or perhaps process the platelets so we can favor a particular secretion, which is skirting on the edge of being more than minimally manipulated, right? And so we'll talk about some of the controversies of that. But the rationale is that you're stimulating platelets to secrete these alpha granules and degranulate in order to use the payload, these growth factors, to activate and help drive healing. And I think this is an important time to kind of pause a little bit. And I think sometimes, I remember, it's teaching some fellows, and they had a little hard time, reconciling, well, is inflammation bad or good? As if, because sometimes we want to squash inflammation, other times we want to use inflammation. And really, I would say inflammation is neither bad or good. I think it's good in the right circumstances and bad in the wrong circumstances. I think what's helpful is to think about inflammation as not an all or none phenomenon. And really, inflammation serves so many different functions, and it's really about how you resolve inflammation, not really how you stop it, okay? There's actually, if you think back to old immunology in medical school, there's 6 different ways to resolve inflammation. So it really comes down to, well, can you drive and influence that so that you drive it down a path of regeneration and remodeling rather than, forming granulomas and degeneration. So hopefully that concept makes sense. And that's really the goal of using these growth factors. Okay. So other variants and other names that are used to talk about PRP or platelet-rich plasma that you'll hear about, I've listed them here. I'll only mention a couple other ones, okay? So some people will actually partially activate platelets to create sort of a gel before they employ the treatment. So that's where platelet gel comes in. And then you can have something called platelet lysate, okay? And in platelet lysate, they use a mechanism, and usually the most common mechanism is through several cycles of freezing and thawing, okay? Where they rapidly freeze and thaw the platelet sample. And that will essentially break open or lyse the platelets so that you have the granules just floating free. And that's the idea behind platelet lysate. So you basically freeze thaw. There's several different protocols on PRP, which causes the platelets to lyse. Then you spin it down and you get all the red stuff out, and you basically have this kind of more purified platelet lysate. So that's what that is. Platelet releasate is slightly different. Rather than breaking open the platelets, what you're doing is you're trying to control the activation, but making it super physiologic. So you're using something like recombinant thrombin or calcium chloride, and basically incubating the platelets with those substances that activate the platelets, cause them to cross-link and release their alpha granules. And then you spin down the platelets, and then you inject the supernatant or the plasma kind of layer. So that's a platelet releasate. And both have been used in areas where you perhaps want to do PRP, but want to keep the amount of particulate or clot to a minimum, such as around the spine or nerves. So that's just where that term comes from. And it's really just platelets broken open or activated. Okay, and we'll talk a little bit more later about autologous conditioned plasma and other kind of variations on the theme. But just paying our attention now back to that test tube that we spun down, right? So there's different methods to make PRP, which I'll review in a moment. Okay, but basically much of them is aimed at trying to isolate the platelets from this buffy coat right here without taking too much RBCs. For the most part, mature red blood cells are considered very antigenic and very pro-inflammatory and catabolic for most of the conditions that we're considering. And so that is why we generally want to keep mostly, especially the mature red blood cells, out of our PRP, out of our BMAC, out of our orthobiologics. There's a small exception, and there's some in vitro and animal data that the very low amount of circulating reticulocytes, so as you recall, these are your immature RBCs that maybe they're either nucleated or they have small remnants of the nucleus still, that these may actually have a anabolic effect, but they're in such few numbers circulating in most healthy individuals that they're not as clinically relevant. Certainly in some systems, they actually try to target that, but for the most part, we are trying to avoid RBCs in PRP. Well, what about the white blood cells? And, Dr. Hosapel mentioned leukocyte-rich, leukocyte-poor, and there have been a number of studies looking at the differences between leukocyte-poor and leukocyte-rich PRP, because as you can see here in that buffy coat, not only do you have platelets, but you have various white blood cells. And this is an example right here. You can see here's your whole blood, and you can see the ratios will kind of flip. Your granulocytes will go down, your lymphocytes will go up in this particular example of a PRP system. But in more recent years, there's been a lot of attention paid to the leukocyte content and its role in regenerative medicine. And right now, what the trend has been is, leukocyte poor PRP for most tendinopathies and soft tissue pathology, and leukocyte-rich for most intra-articular applications. But I'd like to offer that perhaps looking at PRP as simply leukocyte-rich and leukocyte-poor may actually be still too broad and coarse, and that looking at the different subpopulations of the white blood cells and leukocytes may be also important. And certainly looking at certain animal models as well as in vitro data, that it suggests that the activity of lymphocytes and monocytes, for example, in PRP is vastly different than the activity of neutrophils and other granulocytes. I think we're looking at some of that benchtop science. It's become more clear that certainly neutrophils polynuclear cells are mainly catabolic and they're mainly aimed at with their toxic granules to guard against infection in normal function. That perhaps from a regenerative medicine perspective, that those do not have a very valuable role to play in what we're trying to accomplish with orthobiologics. Contrast that to monocytes and lymphocytes is that this same zone where you would gather some of that from the buffy coat is where a lot of peripherally circulating mesenchymal cells can be found, and perhaps this is an area of leukocytes that is valuable. So newer systems have looked at trying to find a way to preferentially take part of the buffy coat while excluding other parts that are less desirable based on this, okay? And so you can see here on this graph in the lower left-hand corner that actually it turns out that the different components of the buffy coat can be relatively predictably stratified or laid out based on their density, okay? So this is an example from buffy coat analysis techniques that comes from studying malaria, okay? But you can see here that your granulocytes, and it makes sense, right? The granulocytes, your polynuclear cells, such as your neutrophils, are going to be much heavier than your monocytes and lymphocytes, which are then going to be much heavier than your platelets, which are then going to be more heavier than some of the heavier proteins that you want to isolate. So perhaps if you were to design a PRP system in order to skim the lesser dense portion of the buffy coat, perhaps you could preferentially isolate mostly platelets while excluding the granulocytes. So hopefully that kind of makes sense. And so just a quick review of different PRP systems that are used to accomplish this. And we've mentioned mainly the buffy coat system. This is probably by and large the most popular or most commonplace type of technique. And again, what you're trying to do, the theory is that you centrifuge out the whole blood and you try to isolate, at least in part, that buffy coat to get the PRP. Okay, so that's what this cartoon demonstrates. There's also what we call so-called plasma-based systems. And so in order to get this sort of 3-layer with a buffy coat stratified kind of centrifugation, usually you have to have a higher rate of spin, higher RPMs in the centrifuge, and for a little bit longer in order to accomplish that. But if you were to spin at a slower spin, okay, less RPM, so sometimes we call that a softer spin as opposed to a harder spin, and for a shorter amount of time, you'll mainly get 2 layers. You'll get an RBC layer, and then you'll get this kind of plasma, which is just which has the buffy coat still suspended within it. So hopefully that kind of makes sense. So most plasma-based systems, they're simply isolating plasma from RBC. That's where it gets its name. And then you dip in and basically just isolate that deeper half of that plasma. So some of the advantages is that it's very easy to get an RBC-free PRP from this system, but you typically get lower platelet counts. And there's some controversy as to what an effective platelet count is, and we can certainly talk about that with the questions later. There are other techniques used to try to isolate PRP. There's one system that has been remarketed and rebranded at least once that uses flow cytometry in order to accomplish the same thing. All right, so what does some of the evidence show? And again, this is just more illustrative, but here's a study, more recent study by Lin Yang and their colleagues in 2019, double-blind RCT looking at symptomatic knee osteoarthritis. What they did was they compared PRP versus hyaluronic acid versus normal saline, and what they found was that at a follow-up at 1 month, all 3 groups improved, but following out beyond that, up to 12 months, that the PRP statistically significantly more improved than the hyaluronic acid and normal saline injection. Here's another recent study. Shetty et al. Looked at a double-blinded RCT looking at plantar fasciopathy, comparing anesthetic and local anesthetic injection compared to with PRP compared to local anesthetic with corticosteroid versus normal saline. And what they ended up reporting at a follow-up out to 18 months, that PRP outperformed corticosteroid and saline at 18 months. Short term, you'll get more corticosteroid symptomatic relief, but kind of followed out to 18 months, PRP outperformed them. So I'm going to shift gears a little bit again and talk about stem cells. We've got a lot to cover. So and I know that we've got a great talk coming up looking at, adipose and BMAC, but this is more conceptual. And, I think that what the idea here was, well, if you think back to PRP, the idea was, well, what if we try, we were injecting platelets trying to get this regeneration to happen. And we'll talk about, whether we really directly get healing or whether we're just helping along the process. But what if we were to actually use stem cells and inject them in there? Could we actually spike, so-called spike healing and regeneration by putting the stem cells in there directly? We know that platelets do kind of, with PRP can, at least in vitro and animal-wise, it's been demonstrated that it can actually increase recruitment of circulating mesenchymal cells, mesenchymal stem cells. But what if we were to actually directly implant those? And that's sort of the idea behind this. Here's a list of different cell types in the adult human body that are often called stem cells. And I want to just call your attention, we're really focusing on mesenchymal stem cells. These stem cells, each of these is very different from the other ones. And so when people say stem cells, the first thing I always try to make sure we're talking about is we're talking about the same thing, okay? And some of the harvesting techniques that we'll talk about, we'll have kind of a mixture of different stem cells. But when we talk about really trying to accomplish our goal of improving musculoskeletal conditions, mesenchymal stem cells is sort of what we're focusing on. Okay, so just remember that here. These other ones, really, I think if you're really interested in regenerative medicine, these are areas which you can really kind of get into and really get into the rabbit hole. Muse cells, for example, these V cells, for example. But I think for the most part, for the purposes of today, just focus on mesenchymal stem cells. But when we talk about stem cells, the second thing I want to call your attention to is not just MSCs, but don't forget, if you want to stay out of trouble, make sure it's homologous and minimally manipulated if you're processing it yourself, okay? And so for a moment, I'm just going to show this right here. This is really just to call your attention that in recent years, there's really kind of a look at trying to categorize and classify different stem cell therapies. In the US, this is a little less important only because the FDA really kind of restricts us to what they call first generation stem cell therapies. This is used internationally to try to study this. And I think that in the future, this might change. But if you notice here, from first to fifth generation, it just kind of increases in the amount of manipulation to the specimen. So we're really at the first generation where you're not manipulating much at all, and you're just concentrating and isolating, versus culture expanding, versus targeting particular cell lines and then directly expanding them, versus genetically modifying stem cells, and even taking stem cells and that are not pluripotent and just reversing that, making them pluripotent. And all of this is being done in a research setting, and some of this is actually done clinically in other countries. So you got to be aware of this, and also be aware that despite how little, and we do have some, literature for BMAC and fragmented fat that we'll talk about, but despite the limited evidence that we have for that, we have even less for these other techniques. But it's important to be aware of them because patients will travel to the Cayman Islands, to New Zealand and Australia to get these, and they'll ask you to advise them as their trusted physician. So looking at mesenchymal stem cells, so these are not your multipotent or totipotent they're not your pluripotent stem cells. You can't grow a whole human out of these, okay? These are stem cells that have a stemness to them. They can grow into different structures, okay? But they've already dedicated themselves down a particular pathway, and it's really down the things that are mesodermally derived. So that's why it gets its name, mesenchymal stem cells, because it really is what makes up the mesenchyme. Hopefully that makes sense. It's got some definitions. So if you really want to get into the literature and read about stem cells, you'll hear about cells having to be plastic adherent, fibroblast-like, and have this characteristic cell markers. And I'll just mention them, CD73, CD90, CD105. And that's important because you will get vendors and you'll get manufacturers come in and say, hey, we're marketing a mesenchymal stem cell product or procedure. And often if you want to vet this, you often ask them, well, show me some of your data, show me what you've been able to isolate from this. And some of us have gone as far as to independently QC or challenge some of these products by getting a kit from them, processing it as instructed, and then sending it to an independent lab to see if we're really getting MSCs as promised or as advertised. And so this is the information you look for by definition for MSCs: plastic adherent, fibroblast-like morphology, and 73, 90, and 105. Okay, so that's the information you want if you want to kind of really take them to task. All right. These MSCs seem to have complex roles in reparative processes, adaptive processes, and various types of musculoskeletal tissues, bone, muscle, cartilage, tendons, etc., and to some extent fascia and nerves as well. We'll talk about this, but it's harvested from various different tissue sources, and probably the most common sources are going to be fat and bone marrow. Okay, and the thing to keep in mind is that these cells don't, in vitro anyways, they don't just provide cells that can produce more cells to engraft into an area to fill in. These cells also secrete a bunch of stuff, just like platelets do. They have a secretome, as we call it, where they secrete various growth factors, chemotactic factors, various modulating proteins, enzymatic, signaling proteins that alter enzymatic activity, etc. Influence vascularization that help set the stage for healing as well. So it's not just this, the cells aren't just designed to provide a substrate by which to grow more cells, but they also help set the stage for healing as well. And then in addition to secreting these signaling proteins, many mesenchymal stem cells, remember that they're fibroblast-like, okay, that they also secrete a collagen matrix around it and a scaffolding that also is important for healing. Okay, and so so these are the three kind of direct mechanisms by which mesenchymal stem cells may participate in healing and regeneration. Now, in recent years, and I'll mention this later, is that there's been a lot more attention paid at what the secretome and the secretory function, this matrix scaffold, and the secretomes of mesenchymal stem cells. There's a lot more attention paid to that and its role in healing rather than the cells engrafting into an area. So much so that Arnold Kaplan and many people, myself including, are starting to consider these messenger signaling cells or medicinal signaling cells rather than calling them mesenchymal stem cells. And I'll make mention of this change in terminology to my patients in order to help educate them as to what these cells really do. Okay. So just a quick couple mentions on BMAC and adipose. I know that we've got a great talk coming up on that. So basically, this is a picture of me tapping some bone marrow here. And what you're doing here is you're doing a bone marrow aspirate, and there's several different techniques to try to increase or maximize or optimize your mesenchymal yield. You're basically tapping bone marrow to isolate these mesenchymal cells. These mesenchymal cells typically like to hug vessels, blood vessels, and they are often also called pericytes. And so that's what you're really aiming to try to isolate here. Okay. Often this is used in conjunction with a PRP as well. There's several sites you can get it from, but I think by and large the most commonly favored site is going to be the PSIS and iliac crest area. So I won't spend too much on this, but you can see from the flow cytometry studies looking at BMAC that it does contain a population of mesenchymal stem cells. I'm sure that we'll hear about the differences in concentrations between adipose and BMAC, but I'll leave it at that. Here's a study supporting its use, just to illustrate the rationale. Emma Denon in 2018 looked at a triple-blind placebo-controlled RCT at intra-articular BMAC versus saline for symptomatic NEA-OA, followed it out to 6 months, looking at both functional scores as well as pain scores, and found statistical significance favoring BMAC. Dr. Chris Centino, most of you here are familiar with him and his work. 2015, he's a big BMAC proponent. And here he is with his study in 2015 looking at shoulder pathology, both a rotator cuff and osteoarthritis, and favoring that use as well. Lipoaspirate concentrate, and this comes in many different forms. I think the rationale comes from looking at those pericytes, those mesenchymal cells that surround some of the vascular, stromal vascular portion of the fat. Okay, so essentially what you're doing is a bit of a liposuction. It's more of a lipoaspirate rather than a liposuction. So think of lipoaspirate sort of like a mini version of liposuction. Okay, so essentially what you're going to do is you're going to liquefy, emulsify, and then using a cannula and using a kind of a rasping technique in order to aspirate this emulsified fat. Okay, and there's different processing systems out there. There's certain, especially outside the U.S., there's gravity systems, fat cake systems, various centrifugation systems that with differing degrees of rinsing and cleaning of the fat. But probably by and large, currently the most popular form is using microfragmented adipose tissue. And so the rationale here is to essentially isolate those pericytes from that fat. Okay, and I won't spend too much time on this, but again, the flow cytometry findings do favor the presence of mesenchymal cells. Now, for both BMAC and aspirate, the rationale, aside from having stem cells, is that that big secretome we talked about. If you look at the growth factors and the growth factor inventory of what's secreted from a typical fat graft or BMAC, is that the concentrations of very similar growth factors of PRP are significantly higher, and so that's one potential as to why these sometimes work and often considered to be used when PRP fails to produce the desirable result. Here's some studies looking at lipoaspirate. Most of this is done using fragmented adipose tissue. Russo in 2017, more of a retrospective observational study looking at MFAT or microfragmented adipose tissue, 1-year follow-up for symptomatic neo-OA, and found some good findings there. Striano in 2018, again, case series looking at shoulder pathology, both OA and rotator cuff tears, 1-year follow-up, and he demonstrated improved functional and pain scores as well. So we're going to shift gears to some things that are not currently available in the U.S., but definitely within reach of our patients. This is kind of interesting territory. And we're going to first talk about skin-derived tenocyte-like cells, okay, or for short, dermal fibroblasts. Essentially, what you're doing here is you're taking a skin biopsy. It's usually just like a punch biopsy, okay, and you're sending it to a company that runs a biological lab that will expand the tenocyte cell population within that punch biopsy or skin specimen, and then they'll expand it, concentrate it, and then send it back to you so you can inject it into a tendon. And so they're going to try to target particular markers for tenocyte-like mesenchymal cells. So you can see here that CD90 is what they're targeting here, okay? And they will try, that's the rationale behind using dermal fibroblasts. Does it work? Well, there's some literature to support it. Here's the Dr. Clark et al. 2011 RCT looking at dermal fibroblasts for refractory patellar tendinopathy. Again, they did a punch biopsy and they cultured, expanded these tenocyte-like cells and injected it back in to the patellar tendon and followed them at 6 months. They found that there was there was symptomatic improvement, a bit of functional improvement, as well as normalization. Does not mean total normalization. It just means a more normal looking ultrasound appearance of the tendon as well. Autologous tenocyte implantation is sort of another idea here, but rather than taking these fibroblast-like cells from the skin, this is sort of analogous to the autologous chondrocyte implantation that we use for cartilage defects. What this calls for is for a small biopsy of a healthy tendon in the same patient, and then that biopsy being used as the substrate to culture expand tenocytes that get sent back and then injected into the abnormal tendon. That's the rationale behind it. Currently not available in the US, it's available in Australia, and I've had at least one patient who went and flew over and got this done with good results. Here's a study from Butcher et al. 2017, case series looking at autologous tenocyte implantation for chronic gluteal tendinopathy. What they did was, again, they did a fine needle aspiration biopsy of the patellar tendon, and then they had a culture expanded and injected back into the glute tendons and followed them out to 12 months and found compared to baseline an improvement of pain and function scores. What about allografts of mesenchymal stem cells? And we've got to be careful when we talk about this, and I'll explain why. But so the market started to think, well, rather than isolating from a person at the point of care. What if a company were to essentially get a cell line of mesenchymal cells, expand them, and then ship them while they're preserved to be used as an injectable product? And so won't get too much into it, but there have been it's been shifted in the past couple of years, but several years ago, you saw an uptake of umbilical cord blood allograft type of mesenchymal as a source for mesenchymal stem cells. And what these companies would do is they would take umbilical cord and Wharton's jelly, the cord lining, certain perivascular tissues within the products of conception of healthy donors, usually from people who had C-sections, be able to get a cell line of mesenchymal stem cells that expressed the correct markers and expanded them. And there are several proprietary processes to accomplish this. And Livium was more recently in the news regarding this. Several problems arise from this. One is that most of the studies on MSK applications were in vitro and maybe one animal model study, and none of these were clinical studies on humans. But more concerning was some of the adverse effects that patients were getting. And so, when they were first trying to ship these, the concern is that if you send it cryopreserved, is that this might devitalize some of the mesenchymal stem cells. They don't tolerate that kind of freeze-thaw kind of cycle. So they would ship it preserved with various additives such as EDTA, etc. But the amount of additives they had to put in there would cause adverse reactions in patients. And so they had to shift the way they preserved it. So they shut down for a little bit, and then they came back with, oh, we got this new cryopreserve technique. And then it turned out that all the stem cells were dead by the time they were deployable. So you're really starting to see this kind of go down. But you will find some people still using products similar to this. Just be wary that the amount or population of viable MSCs are going to be questionable. Okay. But there was, during that time, there was some literature that people were putting out to suggest that it may help. So here is, phase 1, phase 2 trial using an intra-articular injection in a controlled experimental model of umbilical cord MSCs. These are culture expanded, so this is not minimally manipulated, but this was done kind of simulating what would happen in a tissue lab, and found favorable results at 12 months. Let's see, do a quick time check here. Okay, we're doing okay. All right. So next, we're going to shift gears to kind of this dehydrated amniotic and chorionic membrane allograft. And this is still being used fairly widely. And this is, again, taking that idea of products of conception having some sort of regenerative effect. So examples of this include AmnioFix, EpiFix, FlowGraft. And some of you here at the conference probably have some experience using these. But essentially, these are tissue graft allografts isolated from products of conception. And they're usually desiccated and preserved in an off-the-shelf product. They're shelf-stable. And you just resuspend it in fluid and then inject it back in. Now, you need to understand that there are no true living cells in the final injectable product here. And because when it was first marketed, I think there was this implication that perhaps there was some stem cells just surrounding from pertaining to the source in which people got it. But yeah, no, there's been many demonstration now that there's no true living cells in this product. So you can kind of think of it as almost like an off-the-shelf PRP. Here's a study from Gellhorn and Hahn, 2017, case series looking at amniotic allograft, desiccated amniotic allograft for the treatment of patients with various chronic tendinopathies and arthropathies, followed over 9 months, and they showed improvement in function as well as pain. All right, so I think this is where things get, in my mind, kind of interesting. So we've kind of talked a little bit about MSCs, and I've mentioned before that that the MSCs in vitro, not only the rationale is not only do the cells form kind of a population of cells that in theory may grow into new cells, but rather it's really what the stem cells secrete that also may play a role. In the past several years, there have been tons of studies, and I'm just giving some examples here that illustrate that at least the way it's employed in the US is that when you administer MSCs in an injectable form, is that by 48 hours, variably depending on the study, most of the population that you inject, we look at these tagged MSC studies, are no longer viable by 48 hours. That the population that you inject in there do not incorporate or engraft into the target site, and they don't differentiate further. And that was demonstrated by Dr. Kaplan and his colleagues in 2017. But there's still other indicators of stem cell activity. And so the theory here is that perhaps most of the therapeutic effect of MSCs to their target tissue is mainly attributed to their secretome, their production of a collagen matrix, the secretion of various hormones. More recently, this year, a study came out, paper came out just reviewing all the antioxidant effects, which was very interesting. And there's also this idea of exosomes where the MSCs will express and release small microvesicles which contain various growth factors, proteins, and also microRNA that have important roles in healing and adaptation. So really, it's really about what the MSCs do rather than them engrafting. And I'll quote a friend of mine, Dr. Sean Mulvaney, which some of you here know. And what the way he describes it when he teaches, he goes, well, I think of the MSCs, this is a little apt given the recent dates. The MSCs are a bit like the soldiers on D-Day, Normandy Beach. You throw a bunch of soldiers on, most of them are dead by the time they make it there, but they leave a dent. They pave the way for other activity to hopefully gain more ground in the process of healing. And I think that's a humorous but also an apt analogy. All right. So since, along the same lines, there's been a lot of products that have been designed aiming at trying to capitalize on what the MSCs do rather than the MSCs themselves. So for example, placental tissue matrix allograft is a product, and I've used a fair amount of this, where essentially you're taking MSCs, you activate them, have them secrete growth factors, have them secrete their collagen matrix, and then you basically wash off the cells and wash off the cells, and then and collect the growth factors and scaffold, and then isolate that as an injectable product. And so that's the rationale behind placental tissue matrix allograft. So here's a study in 2015, a retrospective cohort study looking at placental tissue allograft, injecting just under 2 cc's for the people with chronic lateral elbow pain attributable to lateral epicondylopathy, followed at 5 weeks and found an improvement in symptom scores. Here's another concept. This is really kind of a variation of PRP, but what they're trying to do is they essentially use a process where they use whole blood and they activate the platelets. Now they activate it not through a chemical mean, but they use this kind of frosted glass surface. There's several different ways of activating platelets. This is one, is these irregular surfaces. And what they do is they activate the PRP while this solution is in motion. And what that does is it creates this kind of matrix that can be used to either fill in defects, and there's even a flowable version of this to inject. Several different brands, Clotbuster is one, but there's no real good clinical evidence to show its use for MSK applications by itself. Okay, I think that the manufacturers really market this as something that you can use as an adjunct to other regenerative medicine techniques, but you'll hear about this. And this is available in the US currently. So this is an older technique, but I think I put it here in the slides because it's sort of a rationale behind using the secretion products of MSCs. And this is autologous conditioned serum, or IRAP. It stands for interleukin receptor antagonist peptide or protein. Okay, so IRAP is essentially a peptide or protein that is an antagonist to IL receptor, IL-1 receptor, which is a huge modifier for inflammation. So by inhibiting or antagonizing interleukin-1 beta, this actually has a huge anti-inflammatory effect. And that's the rationale behind using IRAP. So again, much like ozone, thought to be mainly an anti-catabolic, anti-inflammatory product. You can make this out of autologous blood, but you can also there's also a recombinant version of it that can be injected. So looking at studies here, Al Yang et al. In 2008 looked at a placebo-controlled RCT for IRAP and for symptomatic OA, and a 12-month follow-up found that there statistical significant improvement in pain favoring IRAP over saline. Okay, A2M. Some of you have heard about A2M. So this stands for alpha-2 macroglobulin. And what this is it's a protein that's in the plasma. It's a fairly large protein. And what it does is it sequesters and inhibits metallomatrix proteases. So recall that, I think Chad touched upon this, but there's a huge heterogeneity when it comes to the pathophys of things like tendinopathy and osteoarthritis. And to a certain extent, both problems, whether it's osteoarthritis and tendinopathy, likely have some sort of catabolic mechanism that is at play. And so what this protein does is essentially inactivate some of that catabolic activity, and hopefully be, by way of being anti-catabolic, being anti-degenerative, indirectly being regenerative. There's several different companies that are aiming to capitalize on this. There's an autologous, most of this is autologously processed by blood sample. While there is some work by the company called Cytonics on trying to have a synthetic recombinant injectable version of this. Studies on this is limited, but there is some kind of early clinical data. And here's a study from 2016 from Dr. Scuderi and his colleagues looking at the use of intradiscal alpha-2 macroglobulin, or A2M, for discogenic low back pain. And what they found was that when in the presence of a test that suggested catabolic activity, this is called the fibronectin aggregan complex test that you can get. In the presence of a positive test of catabolic activity, injecting A2M led to benefit in pain scores. So exosomes, this is something that's newer in recent years, and I think we're seeing the use of it go up, go down, level off, but they're still used fairly widely. I've used this a bit. This is, again, capitalizing on that secretory paracrine function of the MSCs. So recall that I mentioned that white blood cells will secrete small microvesicles, which contain a lot of their chemotactic factors, cytokines, but also some microRNA. And we can talk about the role of microRNA if you guys are interested in that. But what this is basically aimed at taking a cell line in a tissue lab, expanding it, basically having them secrete or breaking open, there's different methods of isolating the exosomes and then washing away the cells. So you have just the exosomes, which are very rich in growth factors. The studies are fairly limited. Most of these are in vitro and a couple of animal-based studies when it comes to MSK applications. There's actually a fair amount of clinical data on like wound healing and dermatologic applications. But for MSK applications, it's still very much in its infancy. Shockwave therapy. We put it here as regenerative medicine because I think when you kind of look at what the mechanism of action is, you really start to find some similarities with these other modalities that we're using. Dr. Holsupple mentioned shockwave therapy for the treatment of Achilles tendinopathy, and it's used for several different areas of tendinopathies and enthesopathies. But the idea here is you're using extracorporeal shock wave in order to cause microcavitation in the degenerative tissue, which increases permeability of some of the cells and promotes the release of various compounds that are thought to be thought to promote regeneration. So things like VEGF, nitric oxide, certain interleukins. And these are compounds thought to be anti-inflammatory and anabolic. So here's a study by Romp in 2009 comparing eccentric loading alone versus eccentrics with shockwave therapy. And they found that at 4 months, that both had improved, but there was a greater rate of improvement in those who had shockwave in addition to the eccentric loading therapy. So this next modality is sort of a newer kid on the block. This is looking at electromagnetic transduction therapy. So looking at pulse electromagnetic fields. And mostly this is basically touted as an adjunct to be used along with shockwave. So most of the products that are out there actually have this as an added modality on top of shockwave. And that's what this device that's illustrated here does. But independently of the shockwave, it's been found that in vitro data suggests that it reduces pro-inflammatory compounds, promotes the secretion of nitric oxide, and just kind of does this, it increases, does the same thing that shockwave does, but independent of shockwave. So here's a study, 2017, looking at electrotransduction therapy for Achilles tendinopathy, and a controlled study. Basically, both groups got heel cushions. One group got this electromagnetic transduction therapy, and at 12 weeks, statistical significance for those in the active treatment group. So laser therapy, I think this is the problem with laser therapy is that there's so many products out there, and you have to kind of make sure you're using the right product in order to really know you're getting real therapy. But the rationale here is a class 3 laser, and there's different classes of laser if you're not familiar, and basically causes a phytochemical effect mainly at the mitochondrial level, which can lead to, like many of these other modalities, the secretion of various growth factors from the cells present there that are thought to have a regenerative potential. So, there's a study in 2018 looking at laser therapy and rotator cuff tendinopathy, and comparing, patients with rotator cuff pain and dysfunction, and found that at 6 months that there was statistical significance. All right, a couple more modalities here. Percutaneous needle electrolysis. So this is the use of a needle and electrolytic current within the tendon to cause a local inflammatory effect in order to incite a healing regenerative reaction. Okay, and there are a couple studies to illustrate its rationale surrounding symptomatic patellar tendinopathy and plantar fasciopathy, both of which, the first group with patellar tendinopathy showed an improvement in symptomatic scores, but the one with plantar fasciopathy showed some improvement, but in 7 of the 17 patients showed no improvement. So these next couple slides I added at the suggestion of Dr. O'Connor, and I think he's in the group today as well. And that is, what about exercise? If we're defining regenerative medicine as any kind of modality by which we are trying to cause a regenerative activity within the target cell. And there's several in vitro and basic science studies that suggest that this might happen. We know that exercise has several microcellular effects that can increase the secretion of various growth factors. We know about mechanotransduction and how that plays a role when it comes to the effect of strengthening, such as eccentric and concentric rehab. And so people have started to, a lot of interest looking at regenerative rehab. And I think that that's a term you might hear in the years to come. Not a whole lot of clinical data, but this is just a slide showing some of the in vitro and benchtop science to illustrate that rationale. But I won't go too far into it. Just know that that we do seem to see the expression of these regenerative peptides, as well as changes in stem cell activity in the lab. And then I'm going to mention a couple of these, which I'll save this for my talk that follows. But there's a lot of interest looking at not just what you do to treat inside the tendon, but surrounding the tendon. I'll give a talk later about hydrodissection and for tendons and tendon scraping. But most of you may be familiar with some of Dr. Hackett-Alfredson's work, where he used polydocanol as a sclerosing agent to obliterate neovessels that are surrounding degenerative tendons, such as the Achilles tendon. And then in more recent years, we've seen a lot more interest in using hyaluronic acid and other viscosupplementation peritendinously as a treatment, which I've had some success with as well. And then finally, I'm just going to mention a couple of investigational new therapies that are very early in the pipeline. This was, I think, suggested that I include this from a couple of people on the call. And so here's a product that's being produced and in phase 3 trials currently, looking at, this is basically an attempt at cell and gene therapy for symptomatic knee osteoarthritis. And what they do is they take allogeneic chondrocytes and they retrovirally transduce these chondrocytes to overexpress certain peptides, and these peptides are thought to change macrophage phenotypes, and we'll talk about that if you'd like. But this is very early, and I will just say that this, they haven't really gotten close to applying for FDA clearance in the U.S. In South Korea, they're on their 27th attempt to get FDA approval there, just to give you an idea. But I think what this serves as an example of looking at how to treat our problems, our musculoskeletal problems at various levels, including at the genetic level. Here's another product that has garnered a little bit of interest in regenerative medicine circles, and that's spirifermin. It's a recombinant human fibroblast growth factor, and again, it's looking at those secretory products of MSCs and trying to isolate that and see if you can turn it into a drug, basically. And this is an attempt to do that for osteoarthritis. And then finally, people will use signaling peptides, and I won't go too much into this, but just you'll hear about things like BPC 157, TB500, or thymosin, and these are peptides that are actually fairly available, that are thought to have effects on the inflammatory cascade. And so these are being used by some regenerative medicine practitioners out there. So that was a big whirlwind tour, a huge lay of the land. And I'll give you guys a bit of a break and be able to answer questions. But really, there's a lot out there, and it behooves you to, I think, be able to know how to separate what we know, what we don't know, and really educate patients as to what they're getting. I think stem cells is sort of a bad word in my mind a lot of times, mainly because patients will automatically assume it's implicated that these cells will regrow things. And I have to do a lot of work to educate patients that this is not what's going to happen, at least not the way it's done legally in the US, and that you're not going to grow new structures. It's really the growth factors and the secretory products. And I think patients are sometimes taken aback at what other providers have told them compared to what I tell them. So with that, I will spare you guys any more ear bleeding talk, and hopefully you guys stayed awake for that, and I'll answer any questions.
Hey, Gary, it's Eric. You hear me okay?
Hey, yeah, hey Eric.
Good speech. Thank you, my friend.
Thanks, no worries.
Question. Any secrets, any luck of, I guess, defending regeneratives to insurance? Or are you still sticking with just strict cash on this, or are there any luck in the movement in that?
Yeah, there has been change in recent years as far as getting certain regenerative medicine procedures covered by private insurance, but it's been very locale dependent. So in our area in Northern Virginia and the DC metro area, it's still largely a self-pay, non-covered benefit for patients, meaning that they'll have to pay out of pocket for it. But there is a movement towards some coverage, which is some people interpret that as a good thing and a bad thing. And most of that is surrounding platelet-rich plasma. I think that you're gonna, if you're gonna get covered regenerative medicine treatments, it'll probably start with PRP. But I will tell you that in the places where in the country where you're starting to get some coverage for this, it's covered not very well. So I've heard colleagues saying that it's been covered $150, $200, $230 was where I heard one out west, which, as you know, these kits, depending on the system in which you're making PRP, there's several different techniques. If you're using a kit, a closed system kit, which is arguably probably one of the easiest and safest ways to do it, it's going to be cost prohibitive at that reimbursement. But if you're making your own PRP without using a proprietary kit, it could potentially be something that would be financially viable. But yeah, currently not a whole lot of that happening in our area.
Hey, Gary, this is Fran. Can you hear me?
Yes. Hi, Uncle Fran.
Hey, I sent you something on the chat. Amazing lecture as always. And as I was listening to speak, I was scanning up to date, again, just looking for up to dates read. They document a literature review through May 2020, taking a look at muscle, tendon, and joints, and still are recommending caution with only using these therapies in research at this point in time. And, it's disappointing to see that, but I was just wondering your thoughts on that. And again, I use regenerative therapies as well, but what you make of Up to Date and their literature read with reputable authors like Jill Cook and others.
Absolutely.
Over.
And I have a lot of respect for a lot of people who do that really hard work of combing literature and coming out with some conclusions. And as you know, with any kind of body of literature, it's always going to be difficult to find what the truth is. And the truth is usually not on either extreme, but somewhere in between. I think that no matter how unbiased we get, we all carry our own biases. And I think that one bias that's not included in much of this is the bias of the patient, which they, ethically, they have a say in their own healthcare as well. And so the way I look at it is that, yes, I think that the evidence for some of these is softer or non-existent than, say, others. But I think that the best way forward here, since it is available, and patients will go get it. They will get it from either somebody who's conscientious, very discreet, and be more deliberate, or they'll get it from someone who's a little bit more haphazard and perhaps a little more reckless. And that would be to their peril. And I think that patients are going to get it anyways, especially in the private civilian world. Then I think to do the most good requires us to, be able to wield some expertise to help guide them. And that may include being able to employ these ourselves for the greater good. So I think that, yeah, people have different opinions about it. And I understand the science, but like everything else, even the science lends itself to some interpretation as well. And that's how I kind of reconcile that. And I actually make it very clear to the patient what we know, what we don't know, and what the alternative viewpoints are.
Hey, Gary, that's a great answer. And I would just add, Sean Mulvaney had a wonderful review article in the publication. And you get right to the point, is that the alternatives are not without their own risks.
Mm-hmm.
So, and that's very important. That's often not brought into discussion. Thanks, Gary, for a great lecture.
Oh, thanks a lot.
Hey Gary, this is Tim. How you doing?
Hey Tim, how's it going?
Yeah, blowing my mind every lecture you give. I love it. I just had a quick question about exosomes. I think late last year the FDA, put out a public service alert
Yep.
about exosome therapies, and I'm just wondering how you've seen that impact, kind of, just the market and just the practice, in sports medicine.
No, absolutely. I think so. For those of you who don't know, the FDA put out a statement about exosomes and saying how they're, highlighting the lack of FDA approval, and so forth, and really kind of putting a dampener on that. I think that part of the problem is that there are now multiple providers of exosome products, I think this is going to be evolving, and what that has done is it's brought that into the discussion and my shared decision making with my patients. I have an exosome case coming up in a couple of weeks. I still have patients, despite what they know, still wanting it. And currently, it's you're still allowed to actually buy the product and use it. You're just doing it with knowing that it's not FDA approved. And it's kind of, exosomes is currently sitting in this kind of gray zone because the labs themselves are credentialed and accredited. It's really the product that FDA has come out and said that they can't really say that they approve it. But this is part of that discussion, is that can the FDA regulate biologics? They regulate drugs, and some would say yes, some would say no. And that's part of the gray that's happening. And you'll probably find more legal battles in the years to come. So the way I've kind of negotiated that, and this guy I'm doing exosomes in, he's had it before and saw great results and for his right shoulder. Now he wants it for his left shoulder. And so the way I'm currently counseling patients with that is, once I tell them the full scope of what we know, what we don't know, and what the FDA says about exosomes, I haven't had a newcomer for exosomes since, meaning that most will take that and go, okay, maybe I'll pass on the exosomes. I said, that is totally a reasonable election. I know that some of my colleagues who are very high speed in this, but have also drawn very clear line in the sand about not doing things that are not approved by the FDA, have at least for the time being, abandoned exosomes. And that includes the very good and talented Dr. Mulvaney. But I think that what I've been seeing is my patients who've had good results with exosomes and wanting them employed again in a different area of the body are electing to do so because of their own history. And then I just add that new adjunct and that factoid of the FDA, and we discuss it. We actually spent a lot of time discussing it, but at least two of them have decided to proceed with the exosomes as they have in the past. So I think navigating this environment, it's very gray, which means you're going to have to be skilled navigating that gray, which means that there's no right or wrong answer. It's really what's right for the patient. No worries. And things can always change, right? I mean, in a couple of months, the FDA could say this is totally banned from the US, and they shut down all the exosome labs. And, thankfully I don't stockpile exosomes, but some people do. And so they'll have to figure out what to do with that very expensive inventory. All right. Well, I'll tell you what, I'm going to give people just maybe a couple minutes to stretch while I set up for my next talk. It's currently 9:38. I will start talking at maybe just after 9:41. Just give people a couple minutes because I know we're a little behind. That was a big talk. And we'll shift gears and I'll talk about tendon hydrodissection and scraping in a moment. I'll stay on the line, though, if anybody has any further questions. We can always just chat until I'll plan to start at 9:41, 9:42.